So let's get started. Do you guys have any questions starting out? Like I said, just throw something at me or just make a noise if you can't hear me very well back there. Any questions from last time? We were talking about our surgery meds, our inhaled anesthetics, all of that. No. I did get a new USB mic to try to make my recording sound a little better, so we'll test that out and see how it goes. Or it might not record sound at all, but it looked like it was working, so we shall see. Regardless, let's move forward. We're going to look at our intravenous anesthetics, right? Remember we talked about our inhaled ones? Inhaled anesthetics were good for what? Yeah, usually maintaining a deepened level of sedation, right? As opposed to kind of knocking them out altogether. Versus something like nitrous oxide might be used, say, for, you know, again, not for really deep levels of sedation, but it could be used as like maybe the only anesthetic you're going to use, maybe for a more minor procedure, like a dental thing, something like that. So our intravenous anesthetics are also going to be good for helping to maintain sedation, but they are going to be really good for induction because the IV administration should be pretty fast in terms of onset. So you may find them being used by themselves, or you may find combinations in a lot of cases there. So for instance, has anyone ever run into a patient who has been intubated before? Or is currently intubated, right, on the ventilator? Do they normally have like any IV drips going at the same time? What might they have running? Propofol is a good one, right? So if you see like a white milky substance running into the patient, that's typically propofol, which we'll talk about. Anything else you've ever seen? So antibiotics, but in terms of sedation. Versed I heard, and then usually it's a combination of Versed and, anyone know? Fentanyl is the other big one. Yeah, so Versed, fentanyl is a common combination. Using the two together by combining a benzo plus an opioid, you get synergism there, and that helps to provide the patient, make sure they're nice and sedate. Why is that useful when you have a patient who's intubated and being ventilated? Yeah, it's not very comfortable, right? And it helps with synchrony with the ventilator. So that way we will have the patient actually not fighting the vent, right? So you can find a patient who maybe is lightly sedated, who's maybe starting to wake up a little bit, and they'll start to kind of buck the vent a little bit, and they may have issues with oxygenation because of that. So then you deepen the sedation, they calm back down, and then you can have better synchrony there. Anyway, so as I mentioned, they typically are going to have a little bit faster onset of action. Most of these that we're going to talk about will lack analgesic actions, which is frequently why we combine them with opioids. So typically like a fentanyl infusion is probably most common, but you may run into like hydromorphone or morphine, just depends on the providers and what they're used to using there. And they typically have a pretty quick recovery time. So it depends on the dose that you're giving and the agent itself, but typically these are fairly short acting, which lends them to being used as continuous infusions, right? So what's the benefit of a short acting agent with a continuous infusion? Anyone know? Yeah, I can dial in the dose pretty well, right? So if they look overly sedated, then I can just turn it down a little bit, and the new steady state will be very fast to be very quick to reach that, as opposed to something very long acting. So you would never see like a methadone continuous infusion, because that's a half-life of like over 50 hours or something, versus something short acting. If they're maybe not sedated enough, just bump up the dose and they will typically get to that new steady state, and everything should be pretty good at that point. So a couple of the ones we're going to talk about, we'll talk about our barbiturates. Thiopental will probably be a new one here. We'll get into our benzos, opioids, and then a couple other new agents as well we may have alluded to previously, but we'll talk about them in more detail now. So we've talked about our barbiturates before, certainly things like phenobarb and pentobarb we've mentioned in talks of treatment for seizures. Remember, these are very sedating medications. Thiopental is another one you may see occasionally being used here. And remember, they're working through GABA, right? So they're hyperpolarizing those neurons, allowing chloride to flow in, making them harder to have those action potentials there. In these cases here, we actually find that if patients are getting electroconvulsive therapy, this tends to be a drug of choice for whatever reason. Probably because these are very old drugs, and it was used at the time when ECT was probably a little bit more commonly used in those cases there. But nothing real special about these drugs. They can be equally efficacious as any of the other ones we'll talk about today. Good as induction agents, are good for knocking the patient down in terms of their level of consciousness and then keeping them there. And you will see some cardiovascular effects. So typically these in general will have ability to decrease blood pressure, decrease heart rate overall, and actually, which is also a nice feature here, is it can decrease ICP. What does that stand for? No, actually, it was really good for sedating the insane clown posse. They get too riled up, just knock them down. No, I'm just kidding. Yes, intracranial pressure, right? So in those cases there, if you have patients who maybe had like a head trauma, or maybe they have hydrocephaly or something that's causing that pressure to rise, you can administer something like this and it helps to actually decrease the ICP. That way you don't herniate the brain potentially, right? So that's one good agent you can potentially use in those cases there. Talking about this one in particular, thiopental does cross the blood-brain barrier pretty quickly, so that makes it nice from a onset and offset sort of action. The faster it gets in, the faster it gets out as well. Very nice from that standpoint. Many of these sedatives that we're going to be administering, if we're giving them doses that are high enough, a lot of them are going to knock out the patient's respiratory drive, and so that's an important feature there as well. So oftentimes, that's when I mention intubating patients to keep them ventilated. That's the reason why in a lot of cases is because of the sedatives that we're giving are knocking out their respiratory drive, such that if we're not breathing for them, they're not going to do it for themselves. And if you recall, talking about those different levels of anesthesia, remember when they get down to sort of that third phase is where you can start to lose their respiratory drive in those cases there. So something you're pretty commonly going to see. Now, does that mean, well, I'm not going to pose that as a question necessarily, but depending on the situation you're in, you may not need that deep of a level of sedation, and you can get away with using lower doses, and then you can maybe monitor them from a respiratory standpoint, but they may not need additional support. So frequently when we're doing things like conscious sedations, which I'll talk about a little bit later, like in the ER, we'll frequently have a respiratory therapist who's there to make sure they're at the head of the bed, they're monitoring the patient to make sure that they don't have any issues to where they may need some additional support, say from like a bag valve mask, or they may need to be potentially intubated in some cases there. So as I mentioned, this is a good one for patients with that intracranial swelling due to that decreases in ICP. Next are benzodiazepines. These are frequently adjunctive agents being used for sedation. So as I mentioned before, a lot of our pre-op patients will end up getting a dose of midazolam, either orally or say intravenously, occasionally intranasally. And this is nice because it provides that anterograde amnesia, right? So they'll stop remembering things sort of going forward depending on the dose they received there. Lower doses may have maybe a little bit of a brownout sort of phenomenon versus like, total loss of memory. When I say brownout versus blackout, what does that mean? It's like a blackout means what? I don't remember anything what happens. Like, how did I end up in Mexico? No clue. That's a blackout, right? If you're like, oh yeah, I remember there was a clown involved, that's a brownout, right? Because you remember some details, but maybe not enough details to say why you actually are in that certain place. Does that never happen to you guys? Well, teach their own. Regardless, we're going to see that the anterograde amnesia is a nice component of that, because again, the less the patient remembers may be beneficial if you're, just had a trauma or they're about to go into surgery, something like that. So frequently these will be useful as a pre-medication. As I mentioned, these are also get used frequently for helping keep patients sedated when they're ventilated. So if you go up to the ICU, you'll see a lot of midazolam drips that are being given to these patients here. We typically don't use these as monotherapy in the cases of surgery. They'll be used as an adjunct to something else. So you may see this plus an opioid, or you may see them getting this and then say an inhaled anesthetic or propofol or something like that. So typically not used by themselves. Who else might this be useful for? What are the patients having, say, for instance, seizures, right? This could be a good medication to use for those patients as well. Frequently, if we have patients who have status epilepticus, we're having to give them so many benzos anyway to help control those seizures that frequently they're going to lose that respiratory drive, and that's when they have to get intubated anyway. Also just for airway protection in case they aspirate and things like that. So benzos are very helpful from that situation as well, right? So a couple that we'll use here more commonly, things like our agents that we have parenteral formulations available for. So things like diazepam, lorazepam, and midazolam are typically sort of the most common ones. So for instance, for all of our patients prior to going to surgery, whether it's just for a TNA or whether it's for, say, a scoliosis surgery, something like that, they'll get like an oral or an IV dose of midazolam, okay? Frequently what's nice with kids too is, do kids like to get stuck with needles for their IVs? Not typically, right? So sounds like a silly question. Maybe some people like that. Maybe there's some masochistic kids out there that are just like, stick me again. But you will find that if they are quite anxious, this is good as an anxiolytic because it'll chill them out a little bit. Maybe you can get the IV placed and then you can administer the rest of your medications, whatever you need to. So midazolam's a good one. But for instance, with a lot of post-op kids, if you're worried about things like muscle spasms, so if you can imagine a kid going in for significant scoliosis, they're trying to straighten out that back, you worry about a lot of muscle spasms coming out of surgery, we use a lot of diazepam for those patients. So again, it's just provider preference in a lot of cases and what they kind of are comfortable with. Lorazepam might be a decent one as well. They all work very similar to one another. The dosing is just a little differently based on their potency and their indications. So as I mentioned, Versed or midazolam, great benzodiazepines. This is probably far and away the most common one I see used in surgery, as I mentioned for the pre-op thing. The nice thing with this one is very lipophilic, so it's able to get across the blood-brain barrier, fast onset, nice from that standpoint, right? It also has a nice short half-life, which is why we like to use it as a continuous infusion for a lot of those patients who are intubated and sedated, because again, you can dial in your dose pretty well in those cases there, right? Now, what would happen if you accidentally, say, gave too much of a benzodiazepine? Well, or say, for instance, your patient's overly sedated after receiving a benzo and you'd like to wake them up a little bit faster. This is where we can come in with our antidote. So if you were to say, do like an SAT question, you said, you know, morphine is to naloxone as midazolam is to, you would say flumazenil, or romazicon would be the antidote there. So this is a competitive benzodiazepine receptor antagonist, and basically we can either again use it to help accelerate recovery, so they wake up a little bit sooner, or I would use this in cases of, say, overdose, and you can actually use this to help reverse that and then again wake the patient up. Okay. Could there be any risk you might see with using a benzodiazepine receptor antagonist?
Yes.
Such as what? Withdrawal, very similar to what we saw with opioids. You can induce withdrawal for them for patients who are chronically taking it. For benzodiazepines, I can also induce withdrawal. Could that be a problem for these patients? Is benzo withdrawal a particular issue? What happens when you're used to all that GABA effect around, all of a sudden you take it all away? You start to seize, right? So you can end up having very severe withdrawal effects. So I will tell you that I've probably used Narcan hundreds of times, or I've recommended its use hundreds of times. Flumazenil, I can probably count on maybe two hands how often I've recommended it. It's very rare that you recommend using this for patients who are chronically on benzodiazepines because of that withdrawal risk. Now in the surgical setting, where maybe you have someone who is benzo naive and they've never been on it before, they just got a single dose, maybe either intra-op or pre-op, is that going to be a problem? No problem. Just like if I were to say, take a dose of morphine right now, I'm opioid naive, at least I'm telling you that, right? I'm opioid naive and you give me a dose of naloxone, would I have withdrawals from that? I would not, because I don't chronically have those opioid effects around, right? If a little kid got into, say, an opioid or a benzo and you gave the reversal agent, and if they are naive to those drugs, they also would not have any withdrawal phenomenon. So that's kind of the caveat with these things here. It's only for people chronically taking the meds that you are reversing. But just remember, you know, like Narcan to opioids, you're going to have flumazenil to any of the benzodiazepines. It only works for benzos. It does not work for any barbiturates or anything else, even though you would think that, hey, they're both working at the GABA channel. Well, this is specifically just that benzodiazepine receptor site that this one's working for. This one also doesn't have as fast an onset as like Narcan will, so you don't get really that exorcist kind of look that you can see with like a really full blast dose of Narcan. But it can be useful from a recovery standpoint, again, to wake the patients up a little faster.
So you're saying it is or is not appropriate for chronic use, like ever?
I would recommend highly against it. So that's a good question though. So imagine, like, say I have a patient, and I'm thinking like, I mean, my mind always goes to like overdose kind of settings, emergency medicine settings, right? More than surgery, just because that's what I'm used to. So if I had a patient who say was chronically on benzos and they came in and they overdosed on a whole bunch of those, maybe even they took a whole bunch of opioids, what's the worst thing that can happen to that patient? Why would they die? They would stop breathing, right? So is there anything I can do about that? I can ventilate them, right? So again, you can intubate the patient and wait for the drugs just to wear off. So that is a much lower risk than potentially reversing the benzos and causing them to seize. Because if they start seizing, how do I treat that? I have to give them more benzos, right? In which case, I'm probably going to intubate them anyway. So in those cases there, it's rare that I recommend it because the risks are going to always, most often will outweigh the benefits. So the cases where I have recommended it are typically in children, where again they are benzo naive, and I'm not really worried about them withdrawing at all, right? Or like I said, if you're using it in the surgical setting where patients are not chronically exposed to benzos, maybe they just got a single dose, that they're not going to have an issue either. Again, they're just going to wake up a little bit faster. Okay, can that make sense? All right. Again, talking about our opioid analgesics, again, you're going to find that we're using typically pretty highly potent opioids here. So if you recall, we talked about kind of relative potencies between, say, different opioids. Say, for instance, like morphine versus fentanyl. Which one's more potent? fentanyl, right? Because if you look at the doses between the two, imagine giving, you know, say 5 milligrams of morphine IV, you may be giving only 50 micrograms of fentanyl IV, right? So it's much, much more potent from that standpoint. We like the fentanyl family because it is fairly short acting as well, so it's useful from a continuous infusion sort of standpoint in order to maintain sedation for those patients there. One thing you do want to note when using fentanyl in particular is if you give it too quickly IV, so you give a really fast IV push, there is this issue where you can develop this chest wall rigidity, right? And that can be problematic. Let's say you've intubated the patient, but all of a sudden their chest wall is so rigid you can't actually ventilate them very well. That can be problematic. And so in some cases we had to actually give naloxone to reverse that, or in some cases we'll actually give a paralytic. And I'll talk about paralytics a little bit later here and talk about how we use those. So also we end up seeing that if you're using a lot of opioids post-op, we do run into complications. So typically opioid patients, or they're receiving a lot of opioids post-op, they don't really want to get up and walk around because they're fairly sedated. And so you do find this can lead to prolonged vent support, so a harder time getting them off the ventilator. And what's a big complication of being on a ventilator for a long period of time? Yes, getting pneumonias, right? So we definitely don't want any of those. And also things like GI bladder complications, you can get ileus from this, so that's why we don't necessarily like to use a lot of these. And that's where a lot of our local anesthetics, which I'll talk about later, will come into play to help reduce the amount of opioids they actually need there. And then what we often will do for these patients is either give, you can just give, say for instance, with like our prescription assignments, you can give, say, as needed IV doses, but in some surgical cases, we'll actually install an epidural in the patient and allow that to be administered. And again, that provides more kind of regional support, because basically as high up in the spinal column as the drug gets is kind of how high that the drug's going to work essentially. And that can be very useful because that limits overall systemic opioid amounts that patient's going to be receiving there. So kind of think about like an epidural for like labor. We can do the same thing for surgery potentially, right? As I mentioned, fentanyl and the whole fentanyl family typically gets used pretty frequently in the surgical realm. I'm starting to see more fentanyl being used outside of surgery, but that's kind of where it was relegated to for a long period of time. Now we use a lot more fentanyl like in the ER setting for sure. But remember the sufentanil, remi, and alfentanil are going to be the three that kind of fit into that same family of congeners of fentanyl. And again, the nice thing here is they are going to be pretty rapid acting. So quick onset, quick offset. They allow for easier recovery or faster recovery when they get into the PACU, for instance. Of course, we can use any of them, right? So morphine could be used, hydromorphone can be used. Remember, post-op as well, you might frequently put your patient on a PCA, right? Recall using those, they'll have a continuous infusion potentially, and they'll also have demand doses that the patient can punch in there. And what was sort of the requirements that you need to have for a patient to use a PCA effectively? They have to be kind of like with it enough to actually know, like, to press the button. If you're in pain, press the button, you'll get more medication, right? Or they can not even press the button because maybe they just don't have the dexterity to do so, things like that. Yeah, so those are kind of the most common ones you'll probably run into. I do see a lot of Dilaudid. I do see a lot of morphine. These are probably the most common ones you'll see in the surgical sort of realm. So how come I don't use like buprenorphine for a post-op anesthesia, post-op analgesia? Buprenorphine, what would be a problem with that one? Would you want to give your patients who just came out of surgery and they're in a lot of pain a partial agonist? No, you wouldn't want to do that, right? You want to give them a full agonist. You're a nice provider. You want to say, I don't want you to have any pain. So again, remember, think about the use cases for these different drugs here, right? So you probably not end up using something like buprenorphine. Remember, that's just going to be used for opioid use disorders, and you would know that based on your MAT training that you took, right? Perhaps. But we do sometimes actually use methadone. We actually have some providers that are using an intraoperative dose of methadone, and that's actually helping to, because again, it has a nice long half-life, it's actually helping to decrease some of the post-operative use later on. So you kind of get a nice big dose during the surgery, and then they don't need as much late afterwards because that methadone's kind of sticking around for longer. So you'll see some varying use depending on the setting you're actually working in. Okay, so up next, we have our propofol, or Diprivan. And so as I mentioned, I think I have a picture of this, maybe I have a picture of that, but so again, if you ever see propofol, basically it looks like a big bottle of milk. Okay, does anyone know why it looks like that? Milk of the poppy? No, it's not an opioid, but that's a good thought, right? So the drug itself does not like to go into solution, and so the way we do that was actually put it into an oil emulsion. So whenever you see the kind of white milky substance, that's usually a fat emulsion that we're putting the drug into to keep it stable there to administer it to the patient. You'll frequently see fat emulsions also being used. Anyone know when else we would use that? Well, it's fat, so you can actually give it to feed your patients, right? So if they ever need parenteral nutrition, ever hear of like TPN or total parenteral nutrition, you can administer intralipids via that way too to get their fat content in, along the way, like, you know, another bag that usually contains sugar and amino acids and then a whole bunch of electrolytes, but we'll get that intralipid as well. So anyway, so that's why it's white. That's why it looks like milk, is because it's in a fat emulsion there. But also in some cases, you also want to consider, you know, if I'm having to give really big doses of propofol, or they're on it for a long period of time, you have to worry about things like hypertriglyceridemia potentially. You have to think about the caloric intake they're getting there. Every gram of fat contains how many calories? Do we know? 9. It's actually 9. How about for carbohydrates? 4. And then for carbs? Oh, is it proteins? Proteins are 4 too, so proteins are probably like 3.6, but we just round to 4 anyway. So 9 for fats, 4 for carbohydrates, and 4 for proteins, right? It's a good handy numbers to remember if you're ever trying to calculate macronutrients for your patients potentially. Anyway, so looking at this, so we tend to find that propofol is a really good kind of monotherapy for sedation. So as I mentioned, if you have someone who's like ventilated in the ICU, they may be on a Versed and a fentanyl drip together, right? Not compounded in the same bag, but maybe running concurrently to get that additional analgesic effect from the fentanyl and some of that nice anxiolytic sedative effect from the benzo. With propofol, you get a little bit of both of them together, right? So maybe not quite so much on the analgesia side, but it's a very good sedative. We use this quite frequently for sort of minor procedures as well. So like, you know, if you're going in for like an orthodontic procedure, having your wisdom teeth cut out, you may see that being used there. You'll see this being used for conscious sedations in some cases. Now, when I say conscious sedation, what does that mean? Yeah, the patient may be like somewhat sedate, but they're not like going to be completely out of it. They may still be awake to some degree, kind of with it. And what's the benefit of having your patient still be somewhat conscious? They're breathing on their own, which is again a nice benefit from there. So we'll talk about some other agents we can use those conscious sedations as well. But again, if you think about, like, say, like you get a joint dislocated, like you may get a dose of propofol, kind of knock you out a little bit. It will allow you to be very sedate, be very loosened up, right? So that way you can get the joint back in place. And also it can be useful from a standpoint of an anesthetic quality as well. So you don't remember all the pain you experienced when you saw that bone go back in place, or if you're like reducing a fracture or something like that. So propofol is really good from a sort of more minor procedure, but we use it in surgery all the time too to actually help maintain sedation for those patients. So this is a big mover in terms of surgical use there. So I say ambulatory surgery, that's kind of what I'm talking about. Things where they don't need to go under general anesthesia, but they need to at least be somewhat sedated, so that way you can actually do the procedure you're doing because it's painful. Now, the way this is working is it's actually going to directly stimulate those GABA A channels to open up and allow all that chloride to flow in. So could you use this for seizure management potentially? Yeah, you could actually. So if I had a patient who, say, was having a drug-induced seizure, say, for instance, they had too much lithium on the brain and they were seizing from that, and say benzos weren't working, I might use like a barbiturate as an alternative, or I might actually use something like propofol. That could be a good alternative agent there for those patients there. So as I mentioned, IV sedation in the operating room, you can use it for procedural sedation, sort of like in the ER or an ambulatory care sort of setting, or ambulatory surgery sort of setting. And then we'll see this a lot in the ICUs as well. So as I mentioned, if you need to keep your patients sedate for a long period of time, propofol can be a good one to be used there. However, you have to be careful with some of these drugs that can cause some accumulation. So for instance, with propofol being compounded into a fat emulsion, do you think it's more lipophilic or hydrophilic? Probably lipophilic, right? So what do you think can happen if you have patients who have, say, excessive adipose tissue? It's kind of a higher vomit distribution. It can accumulate. And so even though you may cut the drip off, you may find it takes a longer time for your patient to wake up because the drug has been accumulating for a period of time, right? So again, this is over the course of like days to weeks for some of those patients who have been sedated for a while. So when administering this, you do want to be watchful for the hypertriglyceridemia. That's not typically like in the acute surgical setting, but if they're on it for a long time in the ICU, this is a good thing to check for. And then actually what's interesting with really high dose infusions, you can develop what they call this presa syndrome. It's the propofol related infusion syndrome, when they actually get this metabolic acidosis. It has to do with some of the fatty acid metabolism causing an acidosis. So it's a rare thing, but you'd see it with very high doses or more prolonged sort of use there. In terms of its half-life, it's fairly short, which again is what we like to see being used for continuous infusions, because again, you can dial in your dose pretty quickly there. What's interesting though is that actually is something that can turn your urine green. So again, I like to point out things that turn your feces or urine different colors, because again, it could be something where you're like, I mean, if you walked into an ICU room and you saw that urine looking like that, what would you naturally assume. That looks real infected, and you probably need lots of antibiotics and probably antifungals and maybe just a lot of bleach, just everywhere, all over you, inside you, everywhere. But no, it's actually related to the medication itself. And in fact, if you go and look at my bobblehead in my office, you'll notice I'm holding a green cath bag. That is why, because my students were so taken with the idea that propofol gives you green urine that they immortalized it in my bobblehead. So anyway. Again, I did not order that for myself. It seems like something I would do, but I did not do that. That was a gift. So that's one thing you would want to note with that. Other things to watch out for as well is the hypotension can develop here. And so this is a common thing I'll see a lot of docs do in like the medical ICUs is they'll have a patient who's septic, right? When you're septic, your blood pressure usually does what? Goes down, right? Because you're hypotensive, because you're having this massive body-wide inflammatory reaction. And so I'll actually find that they will have patients who will be on a lot of pressors, maybe like a norepinephrine, epinephrine, dopamine, all at the same time, and they're on propofol for sedation. And I'm like, man, they're on a lot of pressors. And they're like, yeah, we just can't get the blood pressure under control. I was like, well, propofol can cause hypotension too, right? And they're like, oh. And so they end up switching over to Versed and fentanyl, which has relatively little cardiovascular effects in terms of blood pressure. And all of a sudden, guess what? You'd come off the epinephrine, come off the norepi, and then maybe they're just on the dopamine at that point. So consider the interactions you can see here from a pharmacodynamic sort of standpoint, right? Again, apnea can occur, especially the higher doses you might be receiving, which is why you'd want to be really cautious with these patients and maybe in a more ambulatory surgery sort of setting, because you want to make sure to monitor their respiratory drive, make sure that doesn't go away, and then some pain injection site. So what is the big pop culture sort of link with propofol? Michael Jackson, actually. This is what caused him to go into cardiac arrest, because he was not being properly monitored, I guess, at the time, and he got too much propofol. Why did he use propofol? Was he undergoing surgery? Used it for sleep, right? Can you imagine using propofol for sleep? It's like using like an atom bomb to kill a flea. Like, it's just... I mean, you'll go to sleep for sure, but but you will find that things like tolerance can develop to these medications over time. So you probably had definitely a pretty heavy physical dependence on the medication there just to get to sleep in those cases there. Does anyone know that at the Jacksonville Zoo that they actually have one of Michael Jackson's elephants there? He had, at Neverland Ranch, he had a bunch of animals, but I guess one of the elephants got donated to the Jacksonville Zoo. So I used to tell, because when we ran our tox rotations, we'd actually have our rotators and students actually go to the zoo with us to go behind the scenes and check out all the snakes and stuff. And we go by the elephant exhibit and go there. And so I'd point it out and say, hey, how do you know which one is Michael Jackson's elephant? You know how we could tell? It's walking backwards. Very talented elephant.
Learn from the best.
Yes. Anywho, so that's propofol. Really good drug. Probably use it quite frequently, especially in like ER setting. Had one sparkly glove too. So. Anyway, so moving on next, we have etomidate. This is going to be another pretty quick-acting sedative agent. You might not see it being used as often, say from a surgical standpoint, but you'll certainly see it a lot used for what we call rapid sequence intubation. Anyone know what that means? Where you sequentially intubate someone rapidly?
Yes.
Yeah, all right. Basically, that is the practice that we use, in, like an ER setting or an EMS setting, where we're trying to sedate the patient very quickly to allow us to intubate the patient. I'm going to go into more detail on that when we get into the ER setting or ER section later on. But this is one you may see being used there more frequently, but I'll mention it here just because it kind of fits in with the other sort of sedative agents we're talking about. So anyway, this one's a really nice one because it actually doesn't have a whole lot of cardiovascular effects. So you really don't see any changes like in heart rate or blood pressure. So from that standpoint, it's good if you had like a really, say, labile sort of patient. So maybe you're worried about them being hypotensive. This will not have a big effect on that. So that's kind of why we like it in those cases there. Again, no analgesia. It's just going to be highly sedating to your patient, right? So it'll cause them to become unconscious. And the nice thing as well is it's fairly short acting, which we like from an RSI or rapid sequence intubation standpoint, but we'll talk about that later on. And again, if you just get like a single time dose, like you actually have recover within 10 minutes or so, which is a nice short duration of action there. In terms of things I would want to note here as well is that adverse effects, these are things you want to be watchful for. One, you can cause some myoclonic activity, so you may see them kind of jerking around and you may be wondering if that maybe is related to like seizure-like activity, but no, it's just actually the medication itself actually causing that. You wouldn't really see anything on an EEG if you were to perform one of those. A lot of these sedatives as well, when patients are recovering from them, they'll frequently have nausea and vomiting. This is another big one. We're going to see that. So of course, pre-medicating with something like Zofran or something may be a good option for a lot of those patients there. A unique thing with etomidate as well is this adrenocortical suppression, and this is actually really important. So say you have a patient who's coming from the nursing home, they're hypotensive, tachycardic, their white count's through the roof, they have a fever, you're really worried about sepsis, right? And you give this patient, say they need to be intubated because their mental status is starting to wane and they're not going to be able to protect their airway, so you intubate them with etomidate. It actually can cause adrenocortical suppression, actually can kind of shut down the adrenal glands for a short period of time. What sort of implications could that have for that patient? So maybe their glucose would be maybe not well controlled there. Maybe you have hypoglycemia as a result of that. What about blood pressure? What would happen? Yeah, what does cortisol normally do with our blood pressure? Usually increases it, right? Remember those mineralocorticoid effects that actually help to keep fluid in the vessels to keep the pressure up? Well, they can actually have a decrease in that. So you may find patients actually require higher pressor support in order to keep the blood pressure sufficient. Or in some cases, we actually will give them replacement hydrocortisone to give them back what they are maybe missing for a period of time. So that's a really important handoff thing to let patients or let providers know is that, hey, this patient got a dose of etomidate, keep an eye on the blood pressure, keep an eye, maybe they'll need some additional steroids, but you have to just watch it, right? Next we have ketamine, one of my favorite drugs to give. It is pretty fascinating to see this stuff in action. This is going to be an NMDA receptor antagonist, so it's actually working to block glutamate specifically, and actually it's chemically related to PCP. Anyone know what PCP is? It's phencyclidine is the full name. I heard, what is that term? Angel dust, yes. What does someone look like when they're on angel dust?
Really wild, like wired out.
Super wired, super wild. They will have, they talk about them having kind of superhuman strength practically, and they'll be fighting. They can be a really dangerous sort of patient to be around. So fortunately, you don't see a lot of PCP use anymore. Actually, a lot of the bath salts kind of looked a lot like PCP when they're first sort of kind of making their debut. But this is the important thing there is like, why do these patients get so strong when they're on angel dust? Well, it's actually because they don't really feel a whole lot of pain because they're having this dissociative sort of effect. And ketamine actually does the same thing, which is why we like it from a surgical standpoint. So by producing a dissociative anesthetic, it's kind of like shutting off that communication from wherever pain may be happening to the brain itself. And I kind of think about this drug causing sort of an out-of-body experience in a lot of cases there. And so basically the patient will be pretty much unresponsive to outside stimuli, but they may still appear to be somewhat awake. And so you may find that they will talk when they are receiving the medication there, even though they have, a fracture you're trying to reduce and maybe still vocalizing things. They may have some minor reactions, they may be blinking still, and it can be really kind of distressful, especially like in the peds ER, kids coming in to reduce a fracture, and we're giving this medication. The parents, they want their kid to be knocked out, right, because it looks really painful, but they may still have their eyes open, kind of flicking around, but they were like, hey, the kid's not there anymore. Like they're off somewhere else at the moment, even though their eyes are moving. Like they're fine, right? They're not feeling this. Those are good education points to mention there. And frequently, what we'll do is we'll tell, especially our pediatric patients, we'll say, like, hey, like, what do you like to do best in the whole wide world? And they're like, I love to go to Disney World. All right, and we'll say, okay, imagine like having a whole bunch of fun with Mickey Mouse. And then, sure enough, like that's what they'll dream about the whole time. When they come back, we're like, how was Mickey Mouse? He's like, it was awesome. It's like the most vivid dreams they've ever had in their entire life, and they have like a great time with it. Okay. That doesn't mean everyone's going to have a great time with this, and I will get into that in just a moment. So again, it's nice because it's going to be analgesic, it's going to be an amnestic, they're not going to remember a whole lot of stuff here. And again, this is nice because it's one of the few IV anesthetic agents that provide both analgesia and some of the anesthetic properties there. So not many of those will do both, which is nice. Other things to note here as well is that ketamine, very similar to what you imagine with something like PCP causing someone to be really hypertensive and tachycardic, this can do the same thing as well. It actually causes catecholamine release such that you will see pretty reliable increases in blood pressure. You'll see rises in heart rate, right? Depending on the dose and how much you're giving, you may see more or less of that. And then typically you'll actually find that their respiratory drive doesn't take a hit. So they will have, very rarely will they become apneic when taking ketamine, and that's why we really like it from like an ER standpoint, because we don't have to have as big of a worry about needing to support that patient from a respiratory perspective. So we can go ahead and administer this. We don't have to worry about them becoming apneic. Can do our procedure. It has pretty quick offset, so within 20-30 minutes they'll be back up and awake, and they'll be good to get ready to discharge potentially. So we like it from that standpoint. Some people don't like it for in cases of patients with high ICP. So say like had a head trauma or something, there's some concern that it will actually increase ICP. So a lot of people won't use it in that setting. So that's a theoretical concern there. So the interesting thing here and why we may see less use of it in adult patients is going to be this high incidence of post-op psychic phenomena. You know what that means? They can read your minds, perhaps. No, that'd be pretty cool, but not that. Essentially, you can end up, anyone ever heard going into the K-hole? It's not a good place to be. And in fact, my attending in fellowship, his name was Dr. Kunisaki. He's probably like the smartest person I've ever met in my entire life. And whenever you go like and report out a patient to him, you'd go into the K-hole most often, where you'd be like, well, what about this? Did you ask that? And I'd be like, I didn't ask that. Okay, well, did you ask this? I didn't ask that. Did you ask this? I didn't ask that. So then I have to go back and ask like 40 more questions, come back, and that'd be even deeper in the K-hole. Not great. But ketamine K-holes are also pretty bad, because you'll find that just similar to how kids will have really nice dreams about hanging out and playing baseball with Mickey Mouse or whatever, adult patients who may have more or less psychological baggage they're holding on to may have really bad experiences with it. They can have very vivid hallucinations, nightmares associated with this, and they may come out of the drug and they will have this very severe dysphoria where they may be quite agitated, maybe violent in some cases. So you gotta be really careful with that. Most adult patients may not do as well with ketamine as, say, pediatrics will. So a lot of times you'll end up seeing more propofol being used, say for those more minor procedures, being more conscious sedations being done like in the ER, ambulatory care, ambulatory surgery setting, versus say for instance in kids where again we use ketamine almost exclusively, right? So just a little bit of difference in terms of like how we use these medications depending on the patient population. So anyway, ketamine, really good drug from that standpoint. Also, we like it in status asthmaticus because it can actually cause some bronchodilation, right? It's causing release of catecholamines. It's going to cause those beta-2 receptors to be activated. You should be able to see those bronchioles open up, right, and allow for easier oxygenation, which is good. So we wouldn't give it to someone who is just like had 3 doses of albuterol and got some steroids and they're still having a hard time breathing. We would use it for those patients with status asthmaticus who are like getting intubated. This is what we would use to sedate those patients there, right? And again, helping out with that bronchodilation. So just a nice table to kind of compare and contrast the different agents here and how you might use them. Again, I can ask questions on things like contraindications. So for instance, like who would be a bad candidate for ketamine in terms of, or I'm trying to think of another way to word that question. Like what kind of patient would you not want to give ketamine to? Perhaps adults, right? Because of the risk of that dysphoria, the acute dysphoric reactions they can have coming out of it. So that could be one thing, right? Also, ketamine causes a lot of nausea and vomiting, so I would certainly pre-medicate with Zofran for that. I think we did like a brief study at Nemours, and I think we had like 50% patients that didn't get Zofran beforehand threw up, so we just started pre-medicating everyone just to be safe. Who might, or what other patients would be a bad candidate for ketamine? Head trauma, good one, right? What else? What if they were already hypertensive? Not great, right? Because again, it can raise blood pressure and heart rate in those patients. That may not be a good option there. Which one of these agents could potentially lower blood pressure? Etomidate's actually going to be pretty neutral, so you shouldn't see any changes there. Propofol for sure is going to lower your blood pressure, which may be okay, especially in adult patients if they're already hypertensive. But what else? Thiopental, your barbiturates are also going to be very likely to do that as well, right? Versed should be pretty neutral. Fentanyl should be pretty neutral. Again, this is with like typical dosing. Certainly, if you drive it up real high, you can certainly see effects there. But I'm talking about more kind of traditional sort of dosing here. But again, kind of be aware. These are kind of things I might ask questions on a test to say you're sedating a patient. Which one do you want to use? And these are things that we would actually make considerations of. Now, a lot of times, who's actually administering these in a surgical setting? Probably your anesthesiologist, your CRNAs, your anesthesia assistants. However, you may be following up on these patients afterward, or maybe you're in surgery while they're administering these medications. You want to know what's going on with the patient. You want to know what kind of drugs they're getting, so that way you can expect, okay, they're having this kind of effect here. I saw the blood pressure go up. Why is that? Okay, they got ketamine, right? These are things you want to be at least aware of, especially in the post-operative setting. Well, when you're following up on these patients, what did they get? How did it affect them, etc. Right? Or actually, you might be like, say, in the ICU, and you may actually be ordering some of these drips to help sedate your patients, right? So if you're in, say, working in the ICU, you may order a propofol drip, or you may order a ketamine drip, right? Different things like that. Okay, so I mentioned with conscious sedation, this is where we're going to have this alleviation of anxiety and pain associated with, say, doing a procedure here. And typically, we're using smaller doses of these sedatives here, such that they're not having a general anesthesia sort of response. They will still be somewhat conscious, right? They should be breathing on their own. They may be responsive to verbal or physical stimuli. They should still be somewhat with it there, right? And so typically, you'll see things like propofol and ketamine are typically used quite frequently, and things like Versed and diazepam. So especially if you're thinking about like ortho going into that, if you're reducing a fracture, what benefit could benzos provide? It's some of the muscle relaxant effects as well, right? So that can be nice too, because again, normally it might be very hard to reduce that fracture, but by loosening up the muscles, by using something like a benzo and then using ketamine, you can loosen that up and make it easier to actually put that back in place, for instance, right? So a lot of different ways you might be using these medications potentially. Again, I said in kids, we see a lot more ketamine use. In adults, you might see a lot more propofol use. This just tends to be the way it goes, because propofol, while having a higher risk for causing respiratory depression, not going to have any of those dysphoric reactions, right? So anyway, I also forgot to mention, like, ketamine is really good, especially if you ever have children that need ketamine, or if you're like working in the peds ER setting and they get ketamine. Tell the parents when they're waking up, that's when you want to ask them any questions you want answers to, because it's basically truth serum at that point, and they'll cop to anything, right? So anyway. The only advantages to something like benzos and opioids here in particular, if you say, for instance, give too much of the drug, is that those have antidotes, right? So we have Narcan we can use for opioids, we have flumazenil we can use for benzos. None of the other ones have antidotes to them, okay? So what do you do in those cases? Say that a patient gets too much propofol. You're right, you don't do much of anything, right? You support them from a respiratory standpoint, or support the ABCs and just let the drug wear off. Again, these have short half-lives, so fortunately you're not going to have to wait all that long, right? 20-30 minutes, most of these drugs will be out of the system, depending on how much they were getting and how long they're getting it for, essentially, right? So, as I mentioned, using conscious sedation in the ICU, we do this somewhat regularly. We have a lot of patients who may be getting procedures that are done. Say, for instance, like you're in the ICU and the patient needs a BAL, right? They need a bronchoalveolar lavage. This is a setting where you could do potentially conscious sedation for those patients there. Or we'll do it if they require mechanical ventilation. Frequently, they're going to be sedated additionally. So, quite frequently, we're going to be looking at combinations of drugs. They'll usually get like a sedative, hypnotic, and an analgesic agent, so like the Versed plus fentanyl. Or they may get something alone like propofol, as I mentioned there. And frequently we're going to be using our neuromuscular blocking drugs. Anyone know what that means? These are going to be your paralytics, right? So things are going to actually paralyze the patient entirely. We'll talk more about those in details, and we'll actually talk about another drug called dexmedetomidine or presa coming up here. It's another new drug we'll mention. So I'll go over a few more minutes and I'll let you guys go on break. But dexmedetomidine, or Precedex, as is commonly known, is starting to get a lot more use. Like when I was when I was on rotations in school, so like my 3rd and 4th year of pharmacy school, this is when like Precedex was like really starting to come out on the market. And then now a lot of people didn't like to use it very much because it was like very expensive. But I'm starting to see a ton of use of this stuff nowadays, much more so than say 10 years ago. I hate to admit it, but it was 10 years ago I graduated. Okay. Anyway, this one's working as an alpha-2 agonist. So this is actually very similar in action to clonidine. It actually makes sense if you look at the names, dexmedetomidine, clonidine, right? So they have very similar actions. So if you recall, what did clonidine say, for instance, do to your, say, mental status, if anything? Would it like pep you up and be alert and active? If anything, it could be sedating, right? Because again, you're shutting down sympathetic outflow from the brain down, right? What happened to your blood pressure? Typically cause it to go down, right? Heart rate would go down, right? Everything kind of gets depressed overall. Dexmedetomidine will do the same thing, which is nice. So this provides a very light sort of sedation. So for instance, if you were considering, I'm trying to think of a good analogy for this one. Whereas like, say for instance, like propofol is kind of like the high bar there in terms of sedation, being very, very sedate. I can like basically make someone completely unconscious. Precedex is good for a nice light sedation, right? So say for instance, I have a patient who's been intubated for a while, but I want them to start to wake up. They can kind of support themselves, but they're just not kind of awake yet. You can switch them over to something like Precedex to provide just a nice light sedation, and then eventually they can kind of come off on their own. which is nice. Typically, you'll see this as a continuous infusion in a lot of cases because it has a very short half-life. So you'll see this in like surgery, you'll see it used in ICUs most frequently in terms of its use there. I'm actually starting to see a little bit more intranasal dexmedetomidine being used for very light procedures. So that's something you may encounter occasionally as well. Just be aware that with high doses or like big bolus doses, hypotension and bradycardia are going to be the big things you're going to see there, okay? Actually, I know a good analogy. Most of you are probably at like a nice level Presidex drip amount of sedation right now, I would say, right? Some of you may be at propofol level, but right now I'm seeing on average, you guys are about Presidex level. So, and again, when you go into that deep sedation, right, because again, these are all on a scale here, going from conscious all the way down to deep sedation, you're going to find, again, patients not easily arousable, they don't respond to physical stimuli. This is where you need to worry about, again, protecting the airway, making sure they're not going to go apneic on there. And again, it's very almost indistinguishable from that IV anesthesia. So this is where you start getting into things like your ketamine and your opioids and propofol and all of that. It's a much deeper level. Now, it's possible, though, you may give a patient, say, you only want them to get some, a light anesthesia, give them a dose of Versed. Some patients may be more responsive than others, and so you can actually find that they can fall down into that more deep sedation. So anytime you're sedating a patient, you want to have access to respiratory support, right? So you want to make sure they have oxygen available, bag valve masks is available, all that stuff, so that way you can go ahead and support the patient and maybe even intubate if need be. So how do I choose which kind of anesthetic I'm going to use? Usually it's going to be based off of the location and the type of surgery that you might be doing there. Also the anticipated length of the procedure. So for instance, if it's say a displaced fracture, that's a fairly quick procedure to get done once the patient's knocked out. So we'll just do a single dose of ketamine, and then we'll have the patient be basically, not responsive. They're still kind of maybe fluttering their eyes, and they're still breathing for sure, but they're not there anymore. That gives us the time to go ahead and reduce that fracture, go ahead and check, make sure placement's good, and then 20 minutes later, patient wakes up. Very quick procedure, right? Versus something where you may need the patient to be out for a while. Say you're doing like cardiac open heart surgery or something, right? You're going to be using much longer procedure times, such that continuous infusions of medications will be needed there, and different meds may be used potentially. So, consider the age of the patient, their condition, what comorbidities they have that may be complicating things, like what's their blood pressure doing, what's their heart rate like. As I mentioned, make sure that available equipment's there. So, by having equipment to make sure you can intubate the patient, it's always going to be at a bare minimum. And again, you have to ask about, well, have they had anesthesia before? What do they respond well to? What do they not respond well to? And what does the actual provider like to use? A lot of times it's dictated by the anesthesiologists themselves. So, we'll go a couple more slides. So looking at adjunctive agents, again, benzos are nice because they help to facilitate anesthesia, and it's also really good for anxiety before the surgery, which is why we give it beforehand. A lot of those patients tend to be pretty anxious for the most part. Antihistamines you can see being used in a lot of cases. So for instance, if you're having to give like morphine, Benadryl is nice because it can help out with what? Yeah, the itching, pruritus they can get from the histamine that morphine's causing it, right? Sometimes we'll give ranitidine during surgery or prior to surgery. That actually helps to decrease gastric acidity and reflux potentially. Obviously, a lot of Zofran gets used here. What else could I use as an alternative to Zofran for nausea and vomiting associated with these drugs? Reglan's a good one. I see that used quite frequently. Anything else? Phenergan, promethazine can be used occasionally for sure. Any other things? Those are probably the big ones, right? You don't really get into things like, aprepitant and things like that. That's more kind of reserved for like chemotherapy, but certainly like Reglan, promethazine, maybe even prochlorperazine could be used, compazine is used occasionally, but definitely Zofran is probably the top of the mountain at that point. Anticholinergics can actually be used as well. These will also help to facilitate some of the anesthetic sort of qualities there. A lot of our patients prior to going in for scoliosis surgery, and anyone know how long those typically last? Like 6 to 8 hours in some cases they're in surgery, so it's quite long. They will actually get a transderm scope actually put on prior to going into surgery to kind of help out with their sedation and help out with some of the anesthetic qualities there. Remember how what the generic for that drug was? Transderm scope? Scopolamine, yeah, it's a pure anticholinergic. So again, that also, anticholinergics do what for your nausea and vomiting? They reduce that as well. So again, some of these drugs are kind of pulling double or triple duty in those cases, right? Also, anticholinergics are also really nice additionally because they tend to dry things out, so if they're having a lot of secretions, that also can be useful. So we may see something like glycopyrrolate or robenol being used. That can actually help to dry out some of the airway secretions and aid oxygenation a little bit better. So, any questions on that, on those meds? All right, so let's do a 10-minute break. We'll come back and then we'll look at our local anesthetics. Is nausea and vomiting common in both etomidate and ketamine, or just etomidate? It can happen with any of them, right? So just remember that that's a common occurrence after getting sedatives. So just be cautious, be aware that it could happen. I mean, you can see it, maybe not so much after benzos, but certainly etomidate, certainly propofol, ketamine, any of those can potentially do it. So pre-medication with Zofran is pretty common practice in a lot of those cases you'll see there for sure. Cool. Any other questions you all may have? When do we use sucks or rock? We will talk about that in just a few moments here, so just you wait. You guys know what suck or rock means? Succinylcholine, and then what's rock? Rocuronium. You probably learned that sucks, and then rocks. We'll talk about why that is in just a little bit. Deep stuff. I didn't make that one up though, so I'm not going to claim that one. All right, so we were talking about our sedative agents, things that will actually cause us to lose consciousness. Now let's talk about our local anesthetics, which are going to be, will have no effect on consciousness, hopefully, unless you get a really big dose potentially, but we'll talk about that. So of course we're going to mention nociception. We've kind of alluded to these drugs already when we talked about, like, for instance, lidocaine being used for neuropathic pain. We'll talk more about that here sort of in more depth, right? And remember, these painful signals are happening at the site of injury, and then they're traveling via the nerves to the spinal column, back up into the brain, and say, ow, that hurts, right? And so how can we interrupt that? What do we do? Like, just chop off the nerve? Could do that, I guess. You could do like my dad used to do when I was a kid, and I would say, ow, my toe hurts, and then he stepped on my other foot and he says, does your toe hurt anymore? And I was like, I don't know, my other foot hurts. And he said, exactly, it worked. Do we do that? No. So remember, if we can interrupt that transmission of that signal, right, if we could block that propagation of the action potential, you can deaden that sensation. If the sensation never makes it up into the brain, you never would even know about it, right? So this is where that numbness comes from, is because you're deadening all those signals coming into the actual brain itself. And so certainly we can block that centrally, all right? We've talked about opioids being used and how they work a lot in the spinal column and in the CNS to block that sort of perception of pain, to block that incoming signal, but it doesn't do anything to the actual the actual generation and transmission of the signal itself, right? So we're going to look at things that can directly interrupt that and will lead to that numbing effect. Does anyone know what the first anesthetic agent we ever had? Local anesthetic? I put it on there. Cocaine was actually the very first one, if anyone did not know. Carl Jung loved this stuff. Let me tell you what, big fan of cocaine. But it's actually, where does cocaine come from? The coca plant, yes. So you find a lot of that in South America being grown there. So we have a lot of cocaine coming into the U.S. is typically from South America in a lot of cases there. But it's all natural, man. It can't be that bad for you, right? Just like cyanide, it's all natural. But so we actually, when we first got a hold of cocaine, we realized that it had several properties to it, some of which were good from a sort of alertness standpoint. It was definitely will stimulate the CNS. You'll be more awake, alert for sure. You'll feel amazing. But we also noticed it did have some effects to actually blunt pain signals, right? So has anyone ever seen like a movie where someone's doing a drug deal and they're getting cocaine and they wanted to test to make sure it was really cocaine? Remy's doing it. What do? They rub it on their gums to make sure it's real. Why do they do that? Because if it's numbing, because it has a local anesthetic effect, that means it is real cocaine. You don't see that with other substances. Make sure it's not baby powder, right? So anyway, if you ever see that, that's why people would rub cocaine on their gums to make sure that it actually truly is cocaine, because it is a local anesthetic, right? So don't say I'd never taught you anything useful on the streets. Just don't do cocaine. That's actually the best takeaway you can have for this whole thing here. But anyway, basically by block, oh yes, do you have a question?
Would it numb your finger?
Well, it doesn't have high lipophilicity actually cross the skin there. It will probably blunt it. That's why I put it on the gums, because that mucosal membrane will absorb it pretty well there. So good question though, right? Because again, we do use some transdermal local anesthetics, right, based on their lipophilicity. So we do use like transdermal lidocaine quite frequently. So yeah, we'll talk more about that in detail. So anyway, so this is a reversible blockade of those sodium channels, preventing that propagation of the painful signal up into the CNS there. So you will find that as an extension of that, and again, these are local anesthetics, meaning meaning typically you're either applying them locally on the skin or maybe you're infiltrating it into a painful area. But if given systemically, you can run into some problems, right? Because where do we first learn about lidocaine? Yeah, and cardio as an antiarrhythmic, right? So it blocks sodium channels of the heart too to treat arrhythmias, but guess what? A lot of these can actually cause arrhythmias as well. Not only that, but they can also do the same thing in the CNS. You will find there is systemic toxicity if these are used inappropriately. And we'll talk about how to make sure we don't do that in our patients here. So as I mentioned, cocaine comes from the coca plant. So again, there's a lot of processing that goes into that to eventually get the actual cocaine itself. How do people normally do cocaine? Do their nose? What's that term? Well, snorting, yes, but what? No, listen. We are Nova PA Orlando students. We use the fancy terms. Insufflation, right? Yeah, so you insufflate the cocaine, which actually has a whole host of problems in and of itself, right? Because we'll also find that what does cocaine typically do in terms of, say, like your cardiovascular effects? Vasoconstrict, right? So you can see hypertension. It also stimulates the heart, causes tachycardia. So actually you can develop nasal septum perforation for people who are abusing cocaine chronically, because it actually will cause all that vasoconstriction, decrease oxygen delivery, and it will cause tissue degradation there. So if you ever see that, it's a possibility. Anyway, so cocaine was one of the first anesthetics, or the first one that we had there. And then since then we have many more. So we have things like prilocaine, mepivacaine, ropivacaine, bupivacaine. In fact, it has a cane at the end of the name, you know it's going to be a local anesthetic basically. And of course, lidocaine, most people have heard of. We've talked about it before. This is the most widely used one. From a surgical setting, you'll also quite frequently use ropivacaine and bupivacaine. Those are probably the three top ones you're going to see most often, right? Do you still use cocaine at all? Occasionally we will for some ENT procedures, because again, if you're, say, cutting into something, the cocaine can be nice from a vasoconstrictive standpoint because it actually will help to decrease bleeding. It will actually help leave your field a little bit clearer. So it's something we frequently give with lidocaine for injecting it with epinephrine, right? And what does epinephrine do? Vasoconstrict, right? So you're kind of doing the same job that cocaine would normally do without having all the euphoric effects and all the other stuff that goes along with cocaine. So we carried it initially when we first opened up at Nemours. We talked to our ENT docs and they're like, yeah, of course we're going to use this stuff. We'll use it all the time. And of course, it just sat there in the vault and nothing ever happened with it, and we ended up expiring it and getting rid of it, right? So, what they providers say they'll do and what they actually do didn't really match up in that case there. So we no longer carry cocaine, but for a period we did. It was a 4% solution, if anyone was curious. So looking at this, you're going to find that a lot of the differences in why you might choose one local anesthetic versus another typically is going to be based off of the duration of action in a lot of cases there. So for instance, if you're looking at the elimination half-life here on this slide, something like bupivacaine has a nice long half-life of, like, say, 3.5 hours versus, say, something like lidocaine only 1.6. So in some cases, let's say, for instance, we have a patient, say a kid comes in, they say lacerated their finger, they're playing with a kitchen knife or something, which, I would never let my kids do that. They have grabbed a knife off the counter before and come running around the corner like a little axe wield. It's terrifying, but they didn't cut themselves. But let's say they did cut themselves, and we need to, say, infiltrate that laceration site in order to suture it, right? So you can use something like lidocaine, and it will certainly do the job, but maybe it doesn't last quite as long, right? So then the kid has recurrent pain. Maybe you have to, like, treat him with other medications, ibuprofen, Tylenol, things like that. Whereas if you use something like bupivacaine, has a much longer duration of action. So it actually may help to keep that area numb, say, for the next 12, 24 hours potentially, and decrease the overall amount of medication these patients will need, right? So that's kind of the benefit of using local anesthetics. And now we're starting to see that a lot more for things like joint replacements. If I can just infiltrate the area where the pain is with a local anesthetic, overall I'm going to require less systemic pain meds. So I use a lot less opioids, I may need less NSAIDs, because those painful signals just never make it up into the actual brain itself, right? This is why we frequently will use things like epidurals. Like, for instance, if a patient's going into labor and they're about to have a baby, we will give an epidural. It typically has ropivacaine, and actually will have an opioid in there as well. So sometimes you'll see synergy between the two kind of working together in those cases there. So anyway, typically these are pretty lipophilic medications here. If you look at their volumes of distribution, these are actually quite high. So you find that these are, yes, quite lipophilic, and that will actually lead to some issues in terms of toxicity, as we'll see here in just a little bit. So again, how they're absorbed. So how do we normally give these local anesthetics? So you give it via injection, right? So typically you can either give it subcutaneously, intradermally, right into the site of the injury itself potentially. What other ways could we do it? There's topical administration, so we've seen like lidoderm patches, which can be used to actually help for things like neuropathic pain issues, like say shingles or postherpetic neuralgia, things like that. We can also just apply it over the skin itself to numb up the area. So for instance, if we have kids who have implantable ports for central IV access, so again, they're going to be chronic frequent flyers with us, say they have cancer and they're coming back to get infusions, or they're getting chemotherapy, they'll frequently have a port that's in place underneath the skin that we can use to access to get, that way we don't have to keep sticking the kid over and over again. But one ways we can actually help decrease pain when we access that is to actually apply local anesthetic right on top of the site. Or we'll do needle stick analgesia in kids in the ER who are about to get stuck. We'll frequently use a local anesthetic to help prevent pain in those cases there. So anyway, those are kind of the most frequent ways we'll give it. I mentioned epidurally, administering a local anesthetic. One way you'll never ever see these drugs being given is via IV, except for in the case of lidocaine if you're using it for an actual arrhythmia. And the reason is because of pretty severe toxicity we're going to run into if accidentally given IV. So that's one thing we'll actually see in just a little bit. So how they're going to be working, again, has to do with how well they bind to the tissues, right? So the tighter they bind to the tissues, the better effects they're going to be having here. We'll see that things like lipophilicity are going to be playing a role in how they're working here. And also in terms of how much you can give, for instance, things like local blood flow can make a difference, right? More blood flow to the area means more of it can be picked up and be taken systemically, so that may lead to problems. Which is why we may frequently use things like vasoconstrictors along with that. So we mentioned lidocaine with epi, you may see bupivacaine with epi. All that is meant to cause a local vasoconstriction to, one, help decrease bleeding, so maybe it's cleaner for you to actually do your suturing if that's what you're doing. It also helps to decrease the amount you're actually absorbing systemically as well. So I'll give you an example. Let's say, for instance, lidocaine, if I have like a really large laceration that you're repairing, you need to infiltrate that with lidocaine, plain lidocaine. The max dose you could get, for instance, is like 5.5 milligrams per kilogram of lidocaine. If I apply a vasoconstrictor like epinephrine now, using those two together, what do you think happens to that total max dose? Goes up or down? Well, I'm using vasoconstrictor, so I shouldn't be absorbing as much systemically, right? Because I'm decreasing that blood flow. Total dose I can administer actually is going to go up because I don't have to worry about the systemic toxicities. So instead of 5.5, now I can get 7 milligrams per kilogram, right? So again, little things like that can make a difference in terms of making sure that the drug's working, how much we can give, etc. Right? So as I mentioned, these are going to block those voltage-gated sodium channels to prevent propagation of the action potentials there. You may find some other issues as well. So actually some things can actually change how well the actual anesthetics will work. So for instance, you have like elevated extracellular potassium, so you have like hyperkalemia, it can actually make these anesthetics work a little bit better in some cases, right? Because it can affect how the action potentials are actually occurring in the first place. Or for instance, elevated calcium levels can actually maybe antagonize the effects, maybe have them not work as well. Clinically, I don't know that this comes up all that too often, at least I'm not seeing any emergency setting, but maybe in surgical perhaps, but I just haven't run into that. But basically, as I mentioned, you're going to find that when you inject this into the area, and the nice thing too is they like to bind to open channels more so than like say the resting or the inactivated state, which means that the nerve fibers that are sending more signals, which presumably are the ones that are in pain, would be open more often, right? So they're actually going to work better in areas where actually the pain is occurring. You're firing off more of the signals there. So overall, they're increasing threshold for excitation. It's harder to have a signal. They're going to slow down those impulse conductions and overall make it so that it's very difficult to even have the ability to have that action potential and even have that ability to send a signal at all, which is why you get that numbness that actually occurs there, right? And again, all has to do with the dose you're administering. So I'll give an example, like for instance, when my wife was having both of our kids and she was getting the epidural that contained ropivacaine, again, depending on how they're situated, that will determine how high up in the spinal column the drug is getting itself, and that dictates kind of where the anesthesia is occurring at, right? So you usually want to keep it a little bit lower because someone who's giving birth, where do they typically need the anesthesia? Probably below the waist, right? So maybe, below the navel, essentially, depending on how they're kind of positioned there. And so depending on the dose they're receiving, it could be a way where she could actually like move her legs around a little bit, and she can actually help to like kind of move around, help the nurses out somewhat. Or in some cases, when the dose was too high, you could not move her legs whatsoever, right? So all has to do with the dose and how much of that decrease in actual the ability to generate the action potential in the first place actually happens there. And of course, I was like, well, maybe you have too much. Maybe we should like decrease the dose a little bit. What do you think she said when I mentioned that? She was like, if you'd like to be a part of this family anymore, you will not touch that dial or tell anyone to touch that. I said, okay. Oftentimes, if you're in the birthing suite, it's better to be seen but not heard, right? So just be a passive bystander. Anyway, so using a vasoconstrictor, epinephrine is going to be far and away the most common one you run into. Again, that decreases blood flow by about 30% or so, so pretty significant in terms of helping to, again, clean up that site, decrease bleeding, and decrease systemic absorption there. It allows us to give those higher doses, as I mentioned, like 7 mg per kilo versus, say, 5.5. Don't memorize that number, but just to give you the example there. You'll see this is less effective for like really lipid-soluble agents like bupivacaine, because again, they're so lipophilic, they have an easier time absorbing anyway. But again, here, lidocaine with epi is probably the most common one. Bupivacaine with epi is probably the second most common one you run into as well. So what you typically find is that the more lipophilic the substance is, the easier time is going to be interacting with that sodium channel. I mean, it's going to have a faster time actually getting in there and deadening that nerve in terms of sending action potentials there. Whereas things like lidocaine, procaine, bupivacaine tend to be a little bit more water soluble, so maybe they have a slower onset of action. And in fact, for instance, if we have a patient who's coming into the ER, say they are a cancer patient, they're neutropenic, and all of a sudden they have a fever, right? So febrile neutropenia, is that a big deal in a cancer patient? Huge deal, right? Because they can't really mount a good immune response, so who knows where that infection is. They can be really, really sick. So they'll frequently come in, and when they have one of those ports there, we actually tell them before they come in, 30, 45 minutes or so, place on your local anesthetic. So we'll typically do like a lidocaine transdermal. We have something called Elamax, which stands for, it's a lipophilic variety of lidocaine we'll have them apply. So by the time they get into the ER, where we need to get an IV placed, we can actually, the numbness is already set in. We can go ahead and get that IV placed for those patients there. Otherwise, if we put it on right at the time, it's going to take time for it to kick in, and thus you're kind of delaying things, right? When you need to get antibiotics started, you need to get labs drawn, all those things. So some of these drugs do take time, and that's usually the more waterphilic or the hydrophilic ones you're going to see there. Whereas with other ones like bupivacaine, tetracaine, much longer duration of action, because again, they're going to have an easier time interacting with those membranes because they're so much more lipophilic. So as I mentioned, the routes of administration, topical is going to be probably most common. Again, you can potentially find this used for needle stick analgesia. We talked about lidoderm patches being used for neuropathic pain. Injections, as I mentioned, either could be from an epidural or subarachnoid perspective, or maybe just do the nerve endings itself. So if I did like a total knee replacement, you just have a local block at that site in order to make sure those painful signals don't get transmitted up into the CNS. Again, IV, you'd really only ever use lidocaine from an antiarrhythmic standpoint. Even that's now gone away a little bit due to the fact that we have things like amiodarone that typically are a little bit more effective. So how do we choose which one we're going to be choosing? It has to do with like maybe the duration of action that we require. Maybe we don't need a long duration of action. Like if it's for a needle stick, that doesn't really require a whole long duration of action, because once that needle is, or once the actual catheter is placed, you don't need to really worry about it. It's not that painful anymore. Short-acting ones tend to be things like procaine and chloroprocaine. Some intermediate-acting ones include like lidocaine, bupivacaine, and prilocaine. And then you're starting to see things like long-acting ones like bupivacaine, ropivacaine. As I mentioned in surgery, these are two common ones you'll run into. Lidocaine I see a lot in like ER settings. You'll still see it in the surgical setting, but those are probably the top three you'll see. Tetracaine I see a lot being used in the eyes. Why would you use tetracaine for the eyes? If you need to like check for foreign bodies, if you're doing tonometry, things like that. So we use quite a bit of that, either for our ophthalmologists who are doing surgery, or we use it in the ER quite frequently to look for foreign bodies and whatnot. Sometimes you actually see combinations, and this is nice too, because you can use a fast-acting and a slower-acting one together in order to help kind of increase its activity. So for instance, you may find like lidocaine and bupivacaine mixed together, or actually there's one called Imla cream that we use quite frequently topically as a means to help with either for like lacerations, or we'll use it for needle stick analgesia prior to getting IVs placed. And so Imla actually stands for eutectic mixture of local anesthetic. So again, don't say I never taught you anything esoteric in your life. Does anyone know what eutectic means? It's actually really cool. One of my pharmacy professors actually did this in school. He actually demonstrated it, so I don't have any to show you. But basically, it's where two things mixed together actually lower each other's melting points. So you'd actually take solid lidocaine and prilocaine, mix them together, you kind of mash them together, and they would actually turn into a liquid as they mix together. So it's kind of a cool little physiochemical sort of phenomenon. But regardless, the name kind of stuck, as Imla cream kind of just rolls off the tongue. And so that's a frequent topical agent we use in order to prevent pain due to a needle stick, for instance. Now, in terms of systemic effects, this is what you have to really worry about. For one, these can be directly neurotoxic, because not only would they block action potentials from these nociceptive fibers peripherally, but what do you think would happen if I was starting to block the sodium channels in the CNS? seizures can certainly be a risk, right? Because you're interrupting that normal neuronal stability such that you can introduce a new, basically not an arrhythmia, but basically a new signal that can lead to a seizure that can develop there. Oftentimes when patients may be getting, say they're getting an epidural, maybe something infiltrated, they're getting some IV, frequently they'll talk about like a metallic taste in the mouth. That could be a sign of anesthetic toxicity, may clue us in to say, maybe we should decrease the dose here or see how we're actually administering this. Maybe accidentally got into a vein on accident, but that can lead up to excitation, all the way up to seizures in some cases that could be difficult to manage there. So that's one thing we'd want to be cautious with when using some of these due to that neurotoxicity. Other things you can run into, certainly they can have audio-visual disturbances because of that. The levels are too high, systemically speaking. And then the other big thing you can see here as well, as I mentioned, is there's that tongue numbness, metallic taste. That's kind of a warning sign. That should be something you're saying, okay, maybe I shouldn't give any more here. Maybe I should start decreasing my dose and see what else is going on. Because once they start seizing, it can be really difficult to manage. And how would I treat that? Benzos, right? It's always safe to say if you're having a drug-induced seizure, you always give them benzos. Easy way to go. Other toxicities you have to worry about are going to be the cardiovascular effects. And so this is called intralipid right here. So when I talked about the fat emulsion that we put propofol into, this is basically the same thing. This is just minus the propofol, it's just the fat itself. So basically what would happen if, say for instance, something like bupivacaine started blocking sodium channels on the heart? Just like it causes seizures in the CNS, what would it cause in the heart? Cause arrhythmias, absolutely. So these can be very cardiotoxic, and in fact, it can actually cause just straight up asystole, essentially, right? You can basically cause this complete lack of signal transduction there. So this can be really problematic. This is what we really worry about, especially when we first start up like something like a peripheral block or an epidural. And so actually what's interesting is how we treat that. And so one of the kind of like pioneering researchers on this stuff, they actually had these like mouse models, and it was really kind of fascinating. And I urge you, if you're interested, look up some of the stories or some of the articles that were published about reversing local anesthetic toxicity with intralipid, because it's like fascinating. These patients were basically, they will be coding, they'll have no heart rhythm whatsoever. You've shocked them, you've done everything, given them epi, nothing's working. All of a sudden we give them an intralipid infusion, and all of a sudden the heart rate comes right back, they're back in spontaneous circulation. Now, why do you think that would work? Why would giving them fat help with the local anesthetic toxicity? Has to do with the lipophilicity of the drug. So if you have something really lipophilic, it's going to partition off of the heart, and then it will go into this new lipid layer introduced into the patient. And so like I mentioned, these cases here you'll read about if you look it up. Basically you have these patients that have been coding them for 20, 30 minutes. Nothing's working. You give them a dose of intralipid, all of a sudden they come right back. And it's like really kind of dramatic when you read about it. So that is something we always make sure that whenever our anesthesiologists are ordering like peripheral nerve blocks or epidurals, they always have an order for intralipid to go along with that, so that way we can supply that if they do run into any kind of cardiac toxicity there. So bupivacaine is probably the most common one, but really any of them could do the same thing, right? What's interesting as well, kind of a unique toxicity, you'll see this with the drug benzocaine before. So anyone know how benzocaine comes sometimes? Whenever heard of like hurricane spray or benzocaine spray? So something you'll see, sometimes if a patient needs like an NG tube being placed, or if you need any kind of like oral anesthesia, there's a spray you can actually administer, basically spray into the back of the throat, and that will help to numb things up, so that way the patient doesn't start gagging and reacting when you try to place an NG tube down. It's kind of the most common place I'll see that. What's interesting though is that benzocaine itself is a really strong oxidizer, and that can actually turn your hemoglobin over into methemoglobin. So frequently what you kind of hear, like the classic story is that a nurse will have an order for a benzocaine spray to use prior to NG placement. It'll say like spray for, let's say, 2 to 3 seconds, and they'll just go like the whole can will be gone. And you're just like, oh my gosh, that's way too much. All of a sudden your patient turns blue. Patient's cyanotic, but they're breathing and they look fine, they feel fine. Throat is certainly numb. What happened there? So that meant hemoglobinemia, right? So now your hemoglobin, instead of binding oxygen, binds to water, and now the patient looks cyanotic because of that. Thought this like really dark brown colored venous blood when you end up drawing that. So that's kind of a unique thing you'll see with benzocaine specifically causing methemoglobinemia. And how do I treat that? Anyone know? Methylene blue, right? You have a blue patient, you give them a blue drug, and guess what? They turn pink again. So pretty cool stuff if you end up getting to see that. You guys ever heard of a congenital or like a hereditary methemoglobinemia? There's this family that's famous up in Kentucky, and they all developed this this hereditary methemoglobinemia because I guess it was before like Tinder and things like that, so the dating scene wasn't too happening back then. So they kind of kept it on the family, so to speak. And so they had this autosomal recessive gene for this this enzyme deficiency, and they all kind of basically passed it on down. And then now you have this like blue family that has this like resting level of methemoglobinemia kind of at baseline. So kind of interesting. You can look up the blue family of Kentucky, and you'll find some interesting pictures. Anyway, I can speak to that because I'm from Putnam County, so I mean that's just, you know, people like to keep it in the family sometimes. That's what it is. Anyway, so there's kind of two big demarcations for your local anesthetics. We'll talk about the ester anesthetics and then the amide anesthetics, and it has to do with the chemical structure of them. And again, I'm not going to get too in the weeds in terms of talking about the chemical structures of these drugs here. You already sedated enough as it is, but main point being is this actually has clinical implications in terms of allergies. Okay, so frequently we have patients say, oh, I have an allergy to X. Lidocaine, benzocaine, prilocaine, something like that. A lot of patients will still say Novocaine. That's kind of an old school brand name that they just know they got some drug that ended with a cane and they had a reaction to it, right? It's frequently the kind of story you hear there. So I'll tell you that anything that has an I before the cane in the name is considered to be an amide anesthetic. Okay, it contains an amide group in the chemical structure itself. So like lidocaine has an I before the cane, bupivacaine has an I before the name. All these are amides. Okay. If you have a hypersensitivity to lidocaine, you are likely to have a hypersensitivity to bupivacaine. Okay, there's cross-reactivity within that group here. On the other hand, if you get into the esters, they will not have any cross-reactivity. The chemical structure is different enough such that if a patient has an issue with lidocaine, they can receive procaine with no problem, right? Patients tend to have more reactions to the esters than they do the amides, but again, the same principle sort of applies here. You can tell that it's an ester because there's no I before the cane. So cocaine, benzocaine, tetracaine, all of those don't have an I before the cane there, right? So it's a handy way to look at it and say, you know, if a patient has an allergy to lidocaine, what can I give them instead? Well, anything without an I before the cane, right? Makes sense? Little handy trick there. So again, no cross-reactivity between the classes there, but certainly within the class there is a risk, so you would want to be cautious with that. Okay. Sometimes what can happen though is the patients will have a reaction not necessarily to the drug itself, but sometimes by an additive. So for instance, you may find patients who have a reaction to epinephrine, right? They have an epinephrine allergy. Does that make sense? Why not? You'd be dead, right? Because you have epinephrine in your body at all times, right? So typically though, what they have a reaction to is something that gets compounded with the epinephrine. So frequently in that case there has to do with sulfites, right? They have a reaction to sulfites, and that's what they're really having a reaction to. You can get preservative-free epinephrine, and it doesn't include that, and they have no problems here. Frequently here though, they with a lot of the anesthetics, you'll find methylparaben is a frequent preservative that will be in there. Oftentimes patients are having a reaction to that and not the drug itself. Now how can I tell the difference? Not easy, right? You'd have to send them to an actual allergist, and they have to have individual intradermal injections of each of the things individually to find out what they are actually having a reaction to. So not an easy process. That's why most people just say, well, I'm just not going to use that anymore, and I'll use something else there. And again, keep in mind, a lot of patients, every cane is a Novocaine to them, so they may not be able to clearly distinguish which one they actually had a reaction to. So anyway, so you can kind of look at these here, kind of comparing the two together. Again, usually you're going to find that the biggest thing that's going to make your decision here is sort of the setting you're in, and also kind of the duration of action for the drug itself, how long it's going to be working for. Cocaine, again, probably not going to use too frequently, but are you going to see a lot of cocaine in your practice potentially? Depends on where you work, right? So if you're working in the ER, say for instance you're working in downtown Jacksonville, guess what? There's a lot of crack cocaine out there, right? You're going to see that. So it's still good to be aware of the different processes and different things. So for instance, there's a thing, because I don't get to like teach a whole tox course, I'll share this little pearl with you. Has anyone ever heard of a concept called crack eye before? Anyone know what that is? Basically, and again, it goes back to the local anesthetic, so just bear with me here for a second. So, so we mentioned before that typical cocaine hydrochloride has to be snorted, right? Well, can it be smoked? Anyone know? Not itself, right? You have to do what they call freebasing to it to turn it into the freebase form itself, and that's what basic crack cocaine is. You mix cocaine with baking soda or something, you can form these little crack rocks, and that is actually able to be smoked. If you try to smoke cocaine hydrochloride, it actually pyrolyzes, and it's no good, right? But anyway, the point being is that there's a lot of crack cocaine use. You'll see that a lot like in inner city sort of areas there. So we saw a ton of it in Jacksonville. We're right there on 8th Street. We saw all that stuff coming in. A lot of cocaine chest pains. You see all kinds of stuff like that. What would happen though is when you're smoking this cocaine, does all that smoke end up in your lungs necessarily? No, where else might it end up? In your eyes, right? So some of that vapor would get there in the eyes, and guess what would happen to the eyes? they would get numb a little bit, right? So what happens to your blink reflex if you have your eyes all numbed up? You wouldn't have one, and guess what? It got dried out, and they're not blinking like they should be. And guess what happened? They get these, corneal abrasions. They could lead to long-term damage, and so that's actually something you can see, an ocular complication of smoking cocaine. Goes back to the anesthetic properties of it, right? So little tidbit, little things you might not think about, but actually relates back to the drugs themselves and their whole mechanisms. Okay. So any questions on that? All right. So next, let's talk about our sleep agents. Seems appropriate since we're towards the end of the day here. Again, as I mentioned, my YouTube channel actually counts as an ASMR channel, so you can actually just listen to that and have no problem sleeping whatsoever. Thinking about making like a lo-fi chill Dr. Wood to listen to study to as well, so that might be another channel coming out pretty soon, so just wait for that one. Anyway, so a lot of times you have patients who are complaining about sleep disturbances. Obviously, we talked about this yesterday in the behavioral health sim, how frequently things like anxiety and depression can be masquerading as sleep symptoms. That may be their initial complaint coming in. But a lot of people may still have these issues you need to deal with as well. There's a lot of things that can lead to insomnia that most people are not necessarily thinking about. So sleep hygiene is like super, super important. Have you guys covered sleep hygiene before? We'll talk about it here a little bit. So for instance, like my wife would sometimes complain about not being able to get to sleep. And I'm like, why are you having trouble sleeping? And so I like walk into the bedroom. I usually go to bed after her. I walk into the bedroom and she has her iPhone like right here, like blasting all that white light into her retinas. Perhaps you can't go to sleep because of that. She told me to shut up. But point being is that sleep hygiene is something that a lot of people need some help with, right? People will do things like excessive alcohol intake, and that can definitely wreck your sleeping cycle. Caffeine or nicotine use close to bedtime can make it difficult to go to sleep. So there's a lot of issues that go into this, and so it's good for you to not just say, well, here's a medication for that, but to look deeper and to see what could actually be leading to this and hopefully dealing with that, right? Most of the meds we're going to see here tend to be habit forming. Some of them can lead to physical dependence, and actually some may lead to addiction in some cases because a lot of them happen to be controlled substances. But a lot of them, because they're habit forming, what does that mean in terms of if they try to go off of them? You can't sleep anymore, right? They become very habituated to it. Just like Michael Jackson used a lot of propofol to get to sleep. This is going to be very similar. Patients who are coming off of this stuff, they may need to even titrate off of it in order to get to sleep because that rebound insomnia can be pretty significant here, right? And again, who are, in terms of like healthcare workers, who might be really likely to have issues with sleep? Yeah, night shift workers, right? So they have a lot of issues as well because now all of a sudden the circadian rhythm is totally thrown off. You know, like when does your brain make melatonin? At nighttime, right? But they're busy working or they're in the ER where they have all these fluorescent lights coming down, right? So it can really screw things up. So we'll talk about that in some detail here. Obviously, things that can help with sleep hygiene, if you can set like a regular time to go to bed and wake up, that can be useful. You know, the bedroom, typically they mentioned, should only be for sleep or sex only, so don't be using it as your dining room and your TV watching station and all these other things. Really should just associate the bed with like, okay, this is where I go to sleep at, right? Typically, and actually most phones nowadays, which is nice, actually has like a blue light filter on there, so if you don't use that, you recommend them turning that on. Now it's a standard feature for most smartphones and whatnot. To avoid daytime naps. I used to hate daytime naps, but now I've gotten older and I have children. Guess what? Daytime naps are pretty awesome. So just wait until you get out of school. You'll believe me. Regular exercise can help out with this. And obviously, you know, reducing intake of stimulants closer to bedtime can really help out. It's like caffeine, nicotine, try to get rid of that. And obviously, you know, if they are waking up a lot in the middle of the night to go to the bathroom, then cut down their liquid intake as well can be useful. Now, in terms of sleep aids, as I mentioned, we want to correct the underlying issue first if we can, and then we'll find that sometimes the issue is not necessarily with getting to sleep. Sometimes it's staying asleep can be an issue for these patients. And so it may help us to decide what kind of med we're going to use if the issue is more of them having a hard time getting to sleep initially, or if it's the actual staying asleep part, or maybe a combination of the two there. So kind of get a clue for like, you know, is it just taking them forever to go to bed, or are they waking up a bunch in the middle of the night? What's actually going on there, right? Ideally, we'd like to be able to help improve their daytime function, but what do you think is a common side effect of a lot of these sleep meds we're going to give them? Daytime grogginess and drowsiness is going to be a big thing, especially for some of the longer acting medications. So how we choose these may be based on like, well, you know, if you need to get up in the morning and be ready to go right away, like say you have an 8:30 test, like you probably don't want to be super groggy for that, right? So these are things you'd also be considering there. Typically we want to start low dose as possible, and typically for as short a period of time as possible, okay? So starting with the easy things first, so using antihistamines can be pretty much the first stop for a lot of patients here. So you think about things like your diphenhydramines and your doxylamine. So like for instance, Unisom. Unisom is named right there for sleep, right? So doxylamine is a pretty common one you may see being used there. What could be some issues with using things like antihistamines in, say, for instance, like elderly patients? What would do your pulse? Could increase it, right, because of the anticholinergic properties, but how about their mental status? Not great. Is his grandpa just getting more demented than usual, or is it because he's taking some medication that is possibly causing some effects there? So we typically don't like anticholinergics in elderly patients because of that there, right? Typically we find antihistamines are less effective than your benzos, and typically like benzos are kind of like your go-to in a lot of cases there. Less effective, but is usually kind of the first stops. Easy thing to try out. Most patients have probably already tried it by the time they come see you, so you want to make sure that you ask about that to see what has worked for them, what has not. Antidepressants can also be helpful here, so something like a low-dose TCA or even trazodone can be really useful, especially if they have like underlying psychiatric issues. So if they have issues of depression or anxiety, these can also be very helpful from that standpoint. And they're not controlled substances, so anything if they have a history of substance abuse, then this might be good options for them, either antihistamine or something like an antidepressant, right? Here's another one called suvorexant or Belsomra. This one actually has a novel mechanism here. It's working on these orexin A and B receptors, actually blocking those. And so this is good for patients, well, maybe not having issues of actually getting sleep induced for them, but it turns off this kind of wake signaling. So if they have frequent times where they're waking up in the middle of the night, it can help to kind of blunt that. So it's going to be another one you may use occasionally. Obviously, most of these medications, guess what? Somnolence is going to be a pretty common side effect for a lot of them, which may be totally appropriate if they're trying to sleep, right? So that could be pretty useful there. Although there's some adverse effects with this one. So again, if it turns off that wake signal, you can actually end up leading to things like sleep paralysis. Sounds a little terrifying, right? I don't know if I'd want that. Again, probably not the best thing to start out with, but maybe work them up to this if other agents are not working. Even like narcolepsy-like symptoms can happen there. So again, not ideal, but maybe a good backup agent, second or third line. So here's one called Ramelteon or Rosarum. This is going to be a melatonin receptor agonist. Now, where do we get melatonin from? The pineal gland, right? So it produces melatonin usually when the lights go down, right? This is why I really hate daylight savings time. So if you ever have children, or if you have children and you have daylight savings time, it totally wrecks their whole sleep cycle, because you're like, all right, it's 8 o'clock, it's time to go to bed. And they're like, the sun's out. Nope. And you're like, no, you really need to go to bed. And they're like, not going to happen. So guess what, who wins? They do, until I get the doxylamine out, and then I usually have it a little bit easier. Then we're on equal footing at that point. But anyway, yeah, so something like Ramelteon can be useful because it can actually help supplement and actually activate that melatonin receptor. Now, I will tell you, I'm seeing a lot more melatonin use. Is it an FDA-approved product? It is not. So that's one thing to consider too. That's a dietary supplement patients will be taking. If they're taking actual melatonin, it can be quite useful, especially if they have like sleep-wake disturbances or they're on shift work issues, if they're working at nighttime. That can be useful. Keep in mind though, again, that it depends on where you're getting it from. Make sure it's a reputable source in those cases there, right? In fact, like when we do our evening time batches at No More's, when we're getting all the medications that are, for the nighttime period, I can't tell you how many doses of, we probably have like 110 bed hospital. And there's probably at least like 20 doses of melatonin that are going up just from like people continuing their home meds. So it's quite frequent. You're going to see this in children for sure. Anyway, but this one can actually go and directly activate those receptors itself. So again, it could be useful, less habit forming than you see with something like, antihistamine or something. Because again, it's trying to more mimic that natural cycle of getting that circadian rhythm down, right? So then getting to the benzo receptor agonists, these are going to be, and really any benzo could be used here, right? So you could use Xanax, you could use midazolam, any of them would work. There's a few that are specifically designed to use for sleep, and we'll talk about those in just a few moments here. There are some issues though with using these, and so has anyone ever heard about like the Ambien walrus? Well, look up the Ambien walrus. It's well worth a quick Google search, but it's interesting because you'll actually have patients that will have a lot of like sleepwalking, sleep driving in some cases. Not great. They may have sleep eating, so you may actually find weight gain associated with this because they like kind of wake up in the middle of the night, not really conscious of what's going on, walk to the fridge and they're like, I thought I had all this food here, where'd it go? Well, they ate it in the middle of the night, right? I know one of my wife's friends at some point, she was having a lot of sleep issues, was on Ambien for a period of time, and all of a sudden she'd get these packages from Amazon showing up at her door. It's just like, where did this stuff come from? I did not order this. No, it was all ordered at like 3 to 4 o'clock in the morning, right? So very interesting, right? And there's an FDA warning about it, so it's significant enough they decided to warn practitioners, right? Be aware that physical dependence, addiction, all that's going to be the same as any of the benzos we talked about. All of them are also going to be controlled substances, so they're all under the same restrictions as what we've talked about previously, right? So these are good because they can help patients get to sleep a little bit faster. They can definitely, depending on how long the drug is working, can keep them asleep for longer, but the longer the agent you're using or a controlled release preparation, more likely to see that daytime grogginess, right? So it's certainly going to be a risk there. And definitely make sure they're avoiding any other CNS depressants, so not having alcohol intake going on because that's just going to be synergistic there, right? Again, be careful, probably not good for pregnancy. All the benzos are going to be category D for pregnancy. We don't like those there. Why would sleep apnea be an issue? Because they may not get that normal kind of increased CO2 levels stimulating them to breathe. They may have that a little bit depressed, a little bit blunted. That can lead to death in some cases there. And then obviously history of substance abuse, that would be a big risk with these drugs anyway, right? So the three main ones you're going to see here, these are going to be non-benzodiazepine, but they're still working on the GABA A receptor. So these are kind of the new drugs here. We have zolpidem, zaleplon, and S-zopiclone. They call them the Z drugs. So you ever see that, that's kind of what they're referring to. And again, they are going to see that the longer the half-life or the bigger the dose you're going to use, the daytime adverse reactions are going to go up for sure. We also will see tolerance over time, right? So I may say, yeah, it was working really well for me for a couple of weeks, and now all of a sudden it's not really doing the same thing anymore. I'm having more trouble getting to sleep. That is related to that tolerance. So sometimes it's good to try to go on drug holidays if you can, wean them off if they don't really need it, especially if it's just an acute thing that's kind of keeping them up at night, right? You will see rebound insomnia being a big issue with that, right? So again, they will find if you cut off of it too abruptly, they're going to have a hard time going to sleep. So anyway, so here's a couple other ones here. Some other notable benzos you may see used quite frequently include things like temazepam and triazolam. These are nice because they have, at least triazolam has a nice short half-life, so that may be good for someone who's trying to get to sleep, but they have no problem staying asleep once they actually get down, right? So little things like that may lead you to choose one versus the other, right? Another one we have here is called modafinil and then R-modafinil. So obviously modafinil being the racemic mixture versus R-modafinil being just the enantiomer here. Provigil and Nuvigil. So these originally got their use just for patients with like narcolepsy or cataplexy. Helpful that way they will kind of help regulate their sleep cycle a little bit better. You're going to find here that this is also going to be recommended for patients who have shift work disorder. So if they're working nighttime and having a hard time going to sleep, let's say 8 or 9 o'clock in the morning, this is going to be a frequent medication you're going to use for them. Beware that it's a C4, so it's under the same restrictions as a benzo. It could be habit forming. Frequently, I don't see a whole lot of abuse with this medication though, so I don't know that's necessarily warranted, but that's what the DEA decided to do anyway. So any questions on sleep stuff? All right, I'm going to get started on the next set. I'm just kidding, I'm not going to do that to you. Let me see here. Let me answer some questions real quick though. Does seasonal depression have something to do with melatonin increasing too early in the day? Can this be reversed in places with long, dark winter months? I don't know if it's necessarily, it probably has something to do with the melatonin too, but even like light boxes and stuff like that can kind of help out with that, kind of help re-regulate that. Perhaps melatonin may be useful potentially. I don't know, I'm not an expert on the topic, so I couldn't say more than that. And then when I went to Peru, the hostels had cocaine leaves in the lobby to put in tea, which would help with altitude sickness. How does cocaine help with this? Interesting. How would cocaine help with this? That's a good thought. What else? Yeah, so it can stimulate respiratory drive and heart rate, so you can actually pick up more oxygen. You're breathing more times per minute, and so you'll pick up more oxygen to help supply that the decrease. Because remember, the PaO2 is lower there, and so you're not going to be taking as much oxygen as you would at sea level. So that's why you would end up doing that, right? Okay. Any other questions? Good point there. If not, I will see you guys next time.